speaker for this session is Dr. Vishwanath Methi, Associate Professor of Anaesthesiology at Navodaya Medical College, Raichur. Please welcome, sir, to speak on jaundice view, anesthetic considerations for obstructive liver disease.
Start? Yeah. Good afternoon, everyone. Myself, Dr. Vishwanath Methi. I will be speaking on the topic anesthetic considerations for obstructive liver disease. Without going into the physiology and the pathology much, I will straight away go into the obstructive liver disease. So, as you can see in the diagram, the obstruction for the biliary drainage can be in any of the parts of the biliary tree. That is the dotted line you can see. Before that, we can call it as intrahepatic. After that, it is a posthepatic. And this table tells us various common causes of the obstruction of the bile duct. Benign causes are bile duct calculus or the gallstones, pancreatic pseudocyst, biliary strictures, hemobilia, liver flukes, and the worms. Malignant causes are cholangiocarcinoma, gallbladder cancer, pancreatic cancer, ampullary cancer, hepatocellular carcinoma with tumor thrombus, lymphoma, metastatic disease. So this flowchart tells us the bile duct pressure, when it increases, there are subsequent changes which leads to the increased permeability because of the loss of the tight junctions between hepatocytes and the biliary tract, leading to the reflex of the bile into the sinusoids, leading to neutrophilic infiltrations, followed by subsequent fibrinogenesis, and then obstruction of the sinusoids, leading to cirrhosis and the portal hypertension. This diagram tells us how the bile obstruction can lead to the systemic endotoxemia and the cardiovascular changes. So, absence of the bile in the intestine leads to the bacterial overgrowth and increased intraluminal endotoxin. By entering the enterohepatic circulation, this leads to the systemic endotoxemia, and simultaneously we have cholestatic liver injury, wherein there is a decreased function of the Kupffer cells, leading to decreased immunity. And also the cytokine response leads to various systemic diseases, the renal as well as the cardiovascular. This flow chart tells us about the bile obstruction leading to three main changes, that is bacterial infection, then bile duct pressure increase finally leads to the increased bile serum salts and ending up causing various systemic diseases, the jaundice and the increased serum hepatic metabolites. Then hepatic dysfunction causes malnutrition, then acholic stools leads to the coagulopathy because of the decreased absorption of the vitamin K, and the vitamin K dependent clotting factors are decreased. Then bacterial overgrowth leads to endotoxemia. Clinical manifestations, these patients, as we all aware, comes with various manifestations like jaundice, pruritus, clay curdle stews, dark urine, abdominal pain, easy fatigability, and Charcot striate, characteristic of cholangitis. Mainly, I would like to stress upon is the malignancy. The palpable gallbladder indicates as towards the malignancy. Coagulation impairment, as I already told, vitamin K dependent factors are decreased. Not only that, when the disease progresses to a hepatocellular dysfunction, so there will be decreased synthesis of proteins of the fibrinolytic system. This also includes to the leads to the coagulation impairment. The renal changes, it accounts to 6 to 18% in these patients, directly related to the degree of the jaundice. Whenever the bilirubin is more than 20 mg%, so we should look for the renal impairment. The endotoxins entering the systemic circulation may cause the renal vasoconstriction and increase in the vascular resistance, leading to decreased GFR. Blood loss during the intraoperative period and the fluid shifts may be another factor leading to renal impairment. And the depressed cardiac function, as we are all aware, in these patients also leads to the renal impairment. Cardiovascular impairment, we generally see three main changes. Cardiac depression, otherwise called as jaundiced heart, it characterized by bile acids have a negative inotropic and the chronotropic effect. There will be decreased peripheral vascular resistance, decreased blood pressure, and bilirubin and the bilirubirin can induce atropine, bradycardia, and the hypotension. We can see vascular hyporesponsiveness, wherein there is exaggerated hypotension uh, because of the volume depletion. And intravascular volume depletion, the causes what has been explained is third place thirst, loss of the thirst, because of which patient takes less water, and the diuretic and natriuretic effects of the bile salts. And increased secretion of the ANP and BNP is also a cause for this intravascular depletion. When the patient comes for the various surgeries like laparoscopic cholecystectomy or open cholecystectomy and bypass procedures like choledochojejunostomy, and the malignancy patients coming for radical surgeries, we commonly come across the Whipple surgery. So once the patient comes for these surgeries, we should carefully evaluate the patient, manifestations, look for the causes, and especially whenever there is a Whipple surgery and it presses upon the duodenum, there are features of obstruction. So we should look for that. And any presence of habits, drug history, which can also lead to cholestasis, history of blood transfusion, then past history of jaundice surgery and anesthetic exposure. Anesthetic exposure, because many of our anesthetic agents also interfere with the hepatic blood flow, and they may cause hepatocellular injury. Then family history of jaundice and the liver disease we should consider. This table explains us how the biochemical changes will be there. We can see the increased conjugated bilirubin in obstructive jaundice. Then liver enzymes AST and ALT are normal in the initial period. Subsequently, when the disease progresses, we can also see elevation in these enzymes when hepatocellular damage occurs. Alkaline phosphatase and gamma glutamyl transferase as the indicators of the obstructive jaundice. Then urine bilirubin is increased. Urobilination is absent because bile is not secreted where in the intestine where urobilination is supposed to be produced. Alkaline phosphatase, we have seen it increases even before the bilirubin. That is one of the earlier indicator. Then 5-nucleotidase, it is the most specific, and the gamma glutamyl transferase is the most sensitive. Coming to albumin, so there will be a decrease in the albumin levels in these patients, but to detect the decrease in the level, so it takes minimum of 21 days because its half-life is so. Rather, we can detect the changes by looking at the PT and INR. So the half-life of the factor 7, which is around 3 to 6. So these changes we can see at the early time. Then imaging, as I already told, to detect the staging of the disease, especially the malignancy, it is considered ultrasonography to look for the presence of CBD stones as well as the strictures. So what are the risk factors these patients have? Three main independent risk factors like hematocrit more than 30%, serum bilirubin more than 20 milligram per deciliter, and the malignancy. Presence of two of the three risk factors tells us about 30% mortality. This previous speaker has already covered the modified child score. So when the advanced liver hepatocellular injury is there, so such patients coming for the major surgeries, we can see the class A, B, C, they carry the mortality rate anywhere from 10% to 76% in child C. So we can say that the child C class of the patients should not be considered or should not be accepted for the surgery because mortality is very high. Preoperative preparation, we should, whenever there is a time for the preparation, we should try to control the weight, correct the malnutrition, and fat restriction need to be done. Informed consent, as we routinely do. Nil per roll status with IV fluids. Here we should consider the decreased glycogen stores in these patients. So dextrose should be one of the component for the IV fluids. NG for the decompression, especially there is a intestinal obstruction. Antihistaminics for the pruritus. Antibiotics to control the enterotoxemia and the cholangitis. Analgesics, we can consider anywhere from low performing opioids. Paracetamol can be used, but the dose should be reduced. Antacids and anxiolytics, we can use alprazolam, lorazepam, as well as the newer agent rimimazole. Coagulopathy should be corrected with vitamin K, 10 mg IM or IV. FFP, whenever there is a hepatocellular injury, is also present. Renal protection, we should reduce the endotoxemia, correct the IV intravascular volume, maintain the urine output more than 0.5 ml per kg per hour. We can use lactulose 30 ml per oral QID for 3 days to reduce the endotoxemia. So use of furosemide mannitol after the correction of intravascular volume will be helpful, but one study which is published in Current Opinion Critical Care tells us acute kidney injury cannot be prevented even after the IV fluid resuscitation as well as increase in the total organ flow. So the ERCP is one of the modality to decrease the preoperative bilirubin, serum bilirubin, wherein we can use it is a OPD procedure and use MAC with the use of the LMA gastro and the gastrolaryngeal tubes. Here we can use various anesthetic drugs, but be cautious about the spectrum of OD spasm. If at all it occurs, we should use naloxone, glucagon nitrates, and anticholinergics to treat it. The goals of anesthesia for such patients is maintain hepatic blood flow, avoid sympathetic stimulation, hypotension, hypoxia, hypocapnia, and hepatic venous congestion. And factors reducing the hepatic blood flow are controlled ventilation, surgery itself reduces the drugs, alpha agonist, beta blockers, and the vasopressin. Inhalational agents, we should be very careful because, as we all aware, the halothane decreases the hepatic blood flow. And maintain metabolic functions and avoid hepatotoxic agents. Volatile anesthetics, halothane, which should be avoided. Isoflurane is the best because it does not interfere with the hepatic blood flow and the HABR. Desflurane is safe, and sevoflurane, in spite of 2% liver metabolism, it is safe. Nitrous oxide is should be avoided whenever there is a intestinal obstruction. IV agents considered better than the inhalationals because modest impact on the hepatic blood flow. Thiopentone should be avoided because its action is prolonged. Propofol is ideal. It does not interfere with the hepatic blood flow. Etomidate is also safe, but its sensitivity is increased, so reduce the dose. Ketamine has got little effect on the hepatic blood flow. Whenever there is a cardiovascular compromise, we can use it. Benzodiazepines, lorazepam, as we know, hepatic extraction is high, so we can safely use it. Rimimazole is safer, as you can see in this literature. Rimimazole shares the similar action of the etomidate, so it can be safely used. Neuromuscular blockers, so atracurium and cisatracurium are preferred. Among the opiates, morphine should be avoided because the active metabolite stays for a long time, and fentanyl can be used. Fluid correction should be done and target at least 0.5 ml per kg per hour should be used. Goal directed is always better. And in Whipple surgery, we should always restrict the fluid because any overload causes bowel edema, and which is not good. The choice of the fluid should be crystalloid solutions containing the dextrose. Colloids should be avoided, that especially the starch, because it can cause tubular necrosis. The monitoring, CVP, IBP can be used. Regional anesthesia, the consensus is it should be avoided because it decreases the blood pressure and in turn the splanchnic circulation. But this particular study tells us it is also safe. And thoracic epidural anesthesia, general anesthesia is safe, but be careful about the effects of anesthetics on the hepatic blood flow. Postoperative care, analgesia and monitoring should be done. ERAS, by including the ERAS in the conduction of the anesthesia, it will enhance the recovery of the patient, decrease the mortality. And here, preoperative carbohydrate loading, maltodextrin, which I forgot to tell you, it also helps us in better outcome of the patients. So, summary, uh, better understanding of the pathology of the liver disease should be considered, and fluid therapy, control of the endotoxemia, the choice of the appropriate drugs, and following ERAS protocol, we can safely conduct this procedure. Thank you.
Thank you, sir, for that important